Now, how do you prevent CRF in nephrotic syndrome? Generally, nephrotic syndrome is because of minimal change disease in children. If you give steroid, they become responsive and there is a remission. But there will be a steroid resistant cases of nephrotic syndrome. What is the most common histopathology there? FSGS, focal segmental glomerulosclerosis. If it is underlying cause of the nephrotic syndrome, then it will lead to the steroid resistant. Now I like to ask you a question. Even before doing biopsy, based on the proteinuria levels, can you tell doctor is this nephrotic syndrome is due to the MCD, minimal change disease, or due to FSGS? Definitely. A nephrotic syndrome where the total daily protein excretion 24-hour urine is less than 4 grams is more likely to be due to minimal change disease. If at all proteinuria per day is more than 4 grams, even before putting renal biopsy needle only, you can guess that probably it is due to FSGS. If it is due to FSGS, unfortunately it is not steroid responsive, generally it becomes steroid resistant. So for them you need to give long term cyclophosphamide immunosuppressive protocols. So long term chemotherapy is used, but follow up is not every 6 months. You must tell the parents to closely monitor the urinary protein value, 2 plus, 1 plus, 3 plus, all life is between +1 to +3 until child grows more than 10 years of age. The monitoring must be not so delayed, it must be more closer monitoring. Cyclophosphamide, chlorambucil, nitrogen mustard, various things are used as a long term chemotherapy regimes if it is a resistant nephrotic syndrome. But is there any chance that a patient of nephrotic syndrome can go into chronic kidney disease with ESRD, end stage renal disease? Rarely, very rarely, especially with FSGS variant, it is possible. Now emergency tracheostomy is done between 3rd and 4th rings. Generally they say in pediatrics decannulation is difficult after tracheostomy. Once more to bring him wean out of the tracheostomy, decannulation become a difficult job is a very much true statement. Now acantholysis is the loss of the intracellular connection between keratinocytes within the epidermis is the underlying pathology. Patch test, you apply allergen, potential allergen and look for the reaction. It is used for the contact dermatitis and atopic dermatitis. Podophyllin application is definitely teratogenic and it is proven even in topical application to lead to development of fetal anomalies, hence it is strictly contraindicated in pregnancy. What do you mean by critical temperature? Oxygen value of it is 118.6, nitrous oxide 36.4, and for the air it is minus 190 degrees and it is the temperature above which you can't liquefy the air. So that is the meaning of the critical temperature. In malignant hyperthermia, we use intravenous dantrolene as a management, as all of you know. Then who are the 2 major culprits predisposing to the malignant hyperthermia? Succinylcholine like muscle relaxants and halothane like inhalational anesthetics. So don't give them, or if already started, stop them. Then oxygen inhalation need to be given. And what is the newer analog of dantrolene that we are using? Ezumoline is the newer analog of dantrolene. Now some agents are called radiosensitizers, which will increase the radiosensitivity of a given tissue. So the analogs of pyrimidine, analogs of purine, actinomycin dehydroxyurea, electronephenic compounds, bleomycin, they are all known to have the radiosensitizing effect, is a previous question. Then which is radioprotective in nature? It is the emifostin, which is a powerful radioprotective agent preventing the sensitization. Then any amount of increased vascularity will increase the ring enhancing effect of a space occupying lesion in the brain. Abscess being inflammatory will have increased vascularity due to inflammation. Any metastasis to the brain will have an increased vascularity. So that will cause a ring enhancing effect of the contrast material will flow more into the SOL, not infarction or ischemia. Now an ischemic bone, if it has undergone, it will show an increased density on X-ray, and it is because of the subchondral collapse is the underlying pathology in avascular necrosis or any ischemic necrosis of the bone is what need to be remembered. A question on X-rays is a frequent topic in exam. So what was the recent question we discussed in Ames question bank? K-shell, what is Crompton effect? These are all the issues in exam. So and how are the X-rays generated? Will X-ray go and hit the anode or cathode? Is it a particle or a wave, or is it a dual nature? A little philosophy also. So everything you must know about X-rays. Now let us talk about it. It is the positive voltage which is applied to the anode, and negative electrons are attracted across the tube towards the positive anode. And X-rays are considered to be the electromagnetic waves, and they have typically a short wavelength, high frequency, high energy than that of a normal light. And because of the short wavelength and high frequency, they are able to penetrate the materials, and they have got a high penetrability, and they are invisible and electrically neutral in nature. So how many things we finished in the options? Electrically neutral, true. They have high, not short frequency. They have a low wavelength, not high wavelength. Is it large wavelength or short wavelength? Short wavelength. Then they are penetrating. Non-penetrating is a wrong statement. Now they have both particle nature and also electromagnetic wave nature. So dual nature is very much a known thing about X-ray. Now let us talk about the particle nature of them. How do you say it is a particle? Particle means if it hits something, another particle must get displaced. So we have got a photoelectric effect, Crompton scattering, pair production, photo disintegration, various effects of it. In summary, what do you mean by photoelectric effect of X-ray? It is very simple. When X-ray beam goes and strikes, it is totally absorbed into the inner shell of the electron. Then it is basically called photoelectric effect. Whereas Crompton scatter, it will go and hit the outer shell, and it will undergo a deflection of its pathway. So we need to know the concepts about outer shell, inner shell of it, and what happens in Crompton and all. We discussed in more detail in our recent Ames discussion. Now how does CSF appear on MRI? Fundamental question, right? So this is T2 weighted image, and this is T1 weighted. White CSF in T2, black CSF in T1. If radiologists listen this, they will ban my MD degree. So for teaching so crudely, but honestly my first lesson in radiology was in EMD, what is this white, this is black appearing, is this white blood, is what I asked very innocently the radiology resident. So half an hour the radiology senior taught everything about MRI, the essential Carnatic music of marriage is being taught. Actually it is very simple to learn. You must know what are hyperintense lesions, hypointense lesions. Only 4 things can happen to brain or any tissue. What are they? Inflammation, infection, infarction or tumor. Only 4 things can happen in this thing. So it's pretty easy. You can choose MD radiology, more easier life. You write 10 reports, put 20 signatures and collect your big check and then go home and then relax. Suddenly you will get a ticket to New York and it is being sponsored by the Next Lane Diagnostic Center. Thanks for sending 100 MRIs. We expect a similar cooperation and send 1000 MRIs and hope that the headache of your patient, even if it is subtle, our MRI will be waiting to take care of the diagnosis. So then next day you will be waiting. Slight headache is there means immediately you will look for an MRI. So that is the other part of the story, how to sell yourself as radiologist. The nihilistic delusions, entire world is ending. It is also called Cotard's delusion. Cotard is a big scientist who discovered that. He said that everything is dead, he doesn't exist, he is putrefying, part of the hand is decaying, kind of a feelings. This is all the part of the morbid depression is what need to be remembered. Now, what are the features of catatonic schizophrenia? Catatonic schizophrenia, there are 6 criteria: stupor, excitement, posturing, negativism, rigidity, waxy flexibility, and perseveration of the words and phrases like echolalia, echopraxia, etc., etc. And that rigidity is called the Gegenhalten, and it is a characteristic catatonic rigidity that you come across. How do you describe Gegenhalten, doctor? It is that increasing resistance to the passive movements of the limb, and the patient appears to be deliberately opposing the movements of the examiner, is called the Gegenhalten, is a part of the catatonia very much. Then there is one important thing called command obeying, is another thing that you come across in those who are having a catatonic schizophrenia. So waxy flexibility, Gegenhalten, command obeying, all these are the part of it. Then what is somatic passivity? It is a part of the schizophrenia, not specifically catatonic variant. So somatic passivity is a Schneiderian's first rank symptom, where it is the control of various parts of the body, everything by others, influence of the others is the field the individual has called somatic passivity, which is a criteria of schizophrenia, not catatonia. Now, what are SSRIs? Basic question. Last moment psychiatry, psychopharmacology revision is not specifics. At least classification, what are SSRIs, what are tricyclics, tetracyclics, what are norepinephrine reuptake inhibitors, you must at least be sure about. So basically SSRIs are used in depression, anxiety, personality disorders, premature ejaculation, etc. So citalopram, depoxetine, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, zimidaldine, they are all called as SSRIs. Then one of the options given was duloxetine. That was the only thing which is not in our regular literature. So duloxetine is also a serotonin norepinephrine reuptake inhibitor. It is called SNRI basically. So examiner asked only SSRI, so then it should not be included. Then you have got mirtazapine, which is not an SSRI. Then what is the mechanism of mirtazapine, doctor? It is a tetracyclic. It is called as the NASA, which is the noradrenergic and specific serotogenic antidepressant, it is called as. Now what is the advantage of it? Unlike the tricyclics, it does not have a anticholinergic effect, and unlike the SSRIs, it does not have the adrenergic side effects, which are the advantage of mirtazapine, is what need to be remembered. Then how do you treat obsessive compulsive disorder? Fluvoxamine is definitely having an influence. Fluvoxamine, sertraline, paroxetine like SSRIs, clomipramine, and venlafaxine also is very much important. More important is behavioral therapy, which includes exposure and response prevention, is an important part, and psychodynamic psychotherapy also has got some amount of role in the management of OCD. Let us talk about ADPKD. They are small cysts, multiple cysts, bilateral cysts. They are both cortical and medullary, not that they are only medullary, and there is polycystin 1, 2 and 3 types of genes are there. Between the 3, which is most common, that is the next entrance question. So it is a polycystin 3, unfortunately, is the most common out of the 3 which is implicated, and it is a mid-adulthood, unlike autosomal recessive, which is responsible for renal failure in the pediatric population itself, and it arises from the nephrons and the collecting tubules is what need to be remembered. You can see here the elongated, splayed and distorted collecting system in the case of the ADPKD. Now let us talk about pleomorphic adenoma, which is a slow growing tumor. Parotid is the most common location, well encapsulated. And what is the common cause for the recurrence in these people, doctor? There will be small protrusions called pseudopodia leading to multifocality of the tumor, which is responsible and which is beyond central mass. You find all those pseudopodia, and they are responsible for the recurrence of the tumor after the surgical resection is what need to be remembered. Papillary carcinoma has got a good prognosis, and you need to examine multiple sections. Why? because papillary carcinoma will undergo occult metastasis, and that's the reason you need to be very sure to examine multiple sections in case of the papillary carcinoma. Now what is anaplastic carcinoma? It will definitely invade the surrounding tissues, so option B is ruled out. Distant metastases are very much seen in that, and the differentiation of papillary follicle is gone, hence it is called as anaplastic because it undergone terminal differentiation, and it is not well encapsulated is the rule about it. And what are the different variants of it? Spindle cell type, giant cell type, squamoid type, etc., etc. Abdominal compartment syndrome, have you heard of this? We discussed this many times, good number of times. One of the previous topic in AIMS question bank, I believe. So just like our facial compartment syndrome can be there, there can be abdominal compartment syndrome. That will lead to a compromised tidal volume, decreased urine output because renal perfusion is compromised, organ dysfunction can be there, and it can be primary without no reason, or it can be secondary with any visible intra-abdominal malignancy, or it can be a chronic entity. Whenever patient has got cirrhosis with a large ascites, it can increase the intra-abdominal pressure and lead to abdominal compartment syndrome, is what you need to basically remember. Now what is first degree, second degree, third and fourth degree burns? Without question on burns, fluid calculation, Valle's formula, there is, you won't get a feeling of taking an Indian entrance exam, right? So first degree is redness, white flock, minor pain at the site of injury. And second degree is there is erythema, superficial blistering, and it will blanch when pressure is applied if it is a superficial second degree. If it is a deeper second degree, it won't blanch with pressure, that is a difference. And epidermis is lost if it is full thickness, and accordingly we have got a classification in place. If it is superficial thickness, called first degree with epidermis involvement, and there is only erythema. If it is a partial thickness superficial, it is called second degree, and it very much blanches with pressure. And still there is a pain sensitivity, it has not lost the pain. And if it is a full thickness, then all those sensory part is gone, hence it becomes hypoaesthetic then. Then let's go to the next question. Why does esophageal varices occur? Why does gastric varices occur? It is a splenic vein, if it undergoes thrombus, then that lead to gastric varices. So it is the short gastric artery, short gastric vein, which are implicated in the gastric varices. Generally gastric varices and duodenal varices, stomach and duodenal varices will accompany. Isolated gastric varices, if they are there, what is the underlying cause? Think of splenic vein thrombosis. What is the most underlying cause for the splenic vein thrombosis? Tail of the pancreas, if there is any pancreatitis, it will lead to the splenic vein thrombosis is what need to be basically remembered. Now what are the drugs that lead to pancreatitis? There is a big list. But as lesser mortals, we need to remember a few things. Definitely associated with pancreatitis. Azathioprine, sulfonamides, diadenosine, valproate, methyl-dopa, pentamidine, corticosteroids, octreotide and aminosalicylic acid should not be basically forgotten. And even L-asparagine is also implicated. Is furosemide implicated? No. Then which diuretics are implicated? It is the thiazides which are implicated, and ithacrinic acid is implicated, not the furosemide is what need to be remembered. Then there are a set of tumors which are called NETs, Neuro Endocrine tumors they are called as. Carcinoids are a part of it, and it is the small cell carcinoma of the lung, which is also considered to be a neuroendocrine tumor. Accordingly, you have a big classification: insulinomas, glucagonomas, VIPomas, somatostenomas, CRHomas, STHomas. Knowledge is ocean. Then let us talk about the rupture of diaphragm. How do you basically diagnose this? It is the chest radiography single most important diagnostic study. Was the question was on rupture of diaphragm or a diaphragmatic hernia, Dr. Krishna? Huh? Rupture of diaphragm only in exam, true exam also? Okay. Chest radiography, the single most important diagnostic study. There is a hemidiaphragmatic elevation, and we also use ultrasound, new generation CT, MRI, Diagnostic peritoneal lavage also has got a role in identifying. And do you want to do laparotomy or thoracoscopy, which is the preferable choice for you? Generally it is the thoracoscopic repair of the diaphragmatic hernia is being done very much is what need to be remembered. Pseudomyxoma peritonei predominantly is due to the appendiceal origin. In addition, you also have got the other things like ovarian mucinous cyst adenoma also can lead to the pseudomyxoma peritonei. Then the hot flushes in prostate cancer, why do they happen? If there is any androgen depletion. So it can occur because of medical, surgical castration or androgen receptor blockers like LHRH agonists like leuprolide, goserelin, and then any anti-androgen like flutamide, bicalutamide or nilutamide, any of them can lead to androgen depletion leading to hot flushes is what need to be remembered. How do you interpret PSA, prostate specific antigen value? Normally it is between 0.4 to 4 nanograms per ml. 4 nanograms is taken as a cutoff value. Anything above that is more likely, not definite, for prostatic malignancy. There can be false positives, negatives, etc., etc. So PSA greater than 20 means it is more likely to say that it is not benign, rather it is a malignant pathology. I left what is the statistics on false positive, negatives, everything literature on the PSA, you can just quickly review. Please remember all these are meant for reviewing and they are like disposable gloves. Don't try to go word to word and specific about it. If you are paying 50 rupees, at least we should give 50 pages. That is the idea behind it, right? Now the most important thing about PSA, doctor, is velocity is important rather than value. What do you mean by velocity? Today you took the value, after a month you have repeated the value, is there any further increase? So velocity is important rather than the absolute value as a diagnostic meaning of it. Now let us go to the next question. A split skin graft, for it to be taken up by the host, by the recipient, what are the important things that can prevent it or promote it? Wound preparation is very, very important, doctor. If the bacterial count is greater than 1 lakh per square centimeters, it is associated with a higher likelihood of graft failure. One of our students has written it as 1000 organisms per square centimeters. What was given in exam, Dr. Krishna? You recall that this question is given at all? Good, good. There is 1 lakh organisms actually. So there is some reverse engineering we did on these options, considering possibly this could be what is given. Then graft adherence is generally maximal in the first 8 hours post grafting, and the tightness with which bandage is applied and the way the bandage is being changed, the pressure applied, everything will have an impact whether graft will remain there or not is what need to be remembered. The burned hand or a claw hand position in burns, what is the kind of a deformity that you come across? Basically it is also called intrinsic minus deformity, is another name given for the claw deformity, where there is a extension which will occur at the metacarpophalangeal joint, and the thumb typically goes into an adducted position, which is called the claw hand deformity in a burns patient is what need to be remembered. Everything is given in flexion. Okay, I mean at least I have given what exactly is the claw hand in the explanation. Maybe a similar question can repeat in tomorrow's exam. So, so the IP joints will be in acute flexion, interphalangeal, metacarpophalangeal junction become extended, which is the underlying inverse. It's called as intrinsic minus deformity, it is called as. Now hypertrophied scar, is it same as keloid? No. So there is a difference between the two, exactly examiner is trying to test us on that. Keloids, they usually develop after the healing of the skin injury, and the tissue extends beyond the borders of the original wound. Then you call keloid. Whereas in hypertrophied scar, it won't grow beyond the wound margin. So that this is the difference number 1. So option B doesn't apply to the hypertrophied scar. Then hypertrophic scars are erythematous, pruritic, raised fibrous lesions and do not extend beyond the boundaries, and they undergo a spontaneous resolution is the nature of them. So that's the reason pruritus is definitely a feature of the hypertrophied scar is what need to be basically remembered. And if you look at keloids becoming brownish red and then pale as they keep aging, and that hyperpigmentation is a feature of keloids. And most keloids are round, oval or oblong with the regular margins, and there can be a claw-like outline of the keloid is what has to be basically remembered. Let us talk about varicocele. The mere presence of varicocele is not an indication for surgery, the bag of worms appearance. If it is leading to any of the 3 indications, pain, discomfort. Similarly, if the seminal analysis is showing abnormalities like a oligospermia, asthenospermia, abnormal forms of sperms, if there is any testicular atrophy because that heat in the scrotum, loss of testicular size with a flabby testis, then that becomes a indication. So oligospermia, small testis, symptomatic patient, the mere size is not a deciding factor, indications of surgery. A guy is having a bloody stools, colonoscopy shows mucosal granularity, collar button ulcers are seen. On telephone, what is your diagnosis? Ulcerative colitis, which can lead to pyoderma gangrenosum. It can have an association with other HLA associated conditions like the ankylosing spondylitis also, can be the other important features that you can come across. So you must be sure on all the radiology signs of ulcerative colitis, doctor. This session is too short for that. So what are the extraintestinal manifestations of ulcerative colitis? It can lead to gallstones, bile duct carcinoma, migratory arthritis, erythema nodosum, etc., etc. There is a pseudoaneurysm in an IV drug abuser, then what is the management of choice? It is the resection of the aneurysm, and then revascularization is considered to be the management of choice. It is the groin area, femoral vessels, which will show the pseudoaneurysm among the IV drug abusers. If there is a pelvic fracture and the urethral injury is there, what is the triad of features of a urethral injury, doctor? Blood at the urethral meatus, patient is unable to void and there is a palpable bladder, but here there is no palpability, and anuria is there, which is more likely to say that probably there is an associated visceral injury leading to renal shutdown, leading to the development of it. At least from the little clues we can conclude that. Then colorectal carcinoma can be because of the underlying familial polyposis and a high fat content inside the diet, and even Helicobacter was also implicated. Now what are the cause of the bile duct strictures? There are 10 non-malignant, another 10 malignant causes. So post-operative injury, pancreatitis, primary sclerosing cholangitis, HIV, cholangiopathy, orthotopic, liver transplantation, Mirizi syndrome, radiation, polyarthritis nodosa, choledochal cyst. I leave it for you to review the literature in a relaxed manner with a cup of coffee. Now let us go to the intra-articular fractures. Arthrodesis can be done, and open reduction internal fixation is done, and excision is also another option available. The K-wire, Steinman pin, Dolman pin, they are all the ones which are used in the traction. Now this is the typical X-ray of the humerus, which is fixed with a Kirschner wire. In our radiology session we had a sumptuous review on screws, nails, nuts, bolts in orthopedics. Now let us talk about avascular necrosis. It can occur in Perthes, which is osteochondritis. It can also be a complication of the slipped femoral epiphysis, sickle cell anemia it can occur, Kaizen's disease it can occur, Gaucher's it can occur. They are all the predisposing factors. Whenever there is any fracture, it is a vascular injury that need to be taken care, becomes an important priority. Dupuytren's contracture can occur in cirrhotic individuals, alcoholics, diabetes, HIV, epilepsy, trauma, manual labor, smoking, etc., etc. Then what is Botanist deformity, doctor? PIP is in hyperflexion with the DIP in hyperextension is basically called Botanist. Now this is a fundamental 8th class biology question. Osteon means what? Where do you have Haversian canal? To answer this, you get a feeling of going to science exhibition, you are standing as a guide to tell that this is our bone, etc., etc. kind of question. So osteon or a Haversian system is the fundamental unit of a compact bone. It contains the bone's nerves and blood supply, and osteoblasts inside that will be forming the lamellae, and they will be developing into osteocytes. This is how you will have a science exhibition. Osteon, Haversian canal, osteocyte, canaliculi, etc., etc. And one osteon and other osteon through the periosteal connection, they are connected with each other, and osteons in turn are connected by the Workman's canals, and osteoclast will be removing the old osteons, osteoblasts will be forming the new osteons. That is how the process goes on and on. Then what are all the causes of the rocker bottom foot? It can be due to overcorrection of the equinus in varus position, vertical talus congenitally, and tell me doctor, which is the trisomy not 21, which can lead to rocker bottom foot? Very good, Edwards syndrome. So trisomy 18 can lead to a prominent calcaneus with a rounded bottom is what you have in the rocker bottom foot, and this kind of a congenital vertical talus also can lead to the rocker bottom foot is what need to be remembered.